Good morning, everyone. I'd like to welcome you today to the Mirowitz Center Fell Group program. And we have Dr. Terri Rebmann. She is a returning person from a previous program early on in the COVID. Dr. Rebmann is the Associate Dean for Academic and Faculty Affairs, Director of the Institute for Biosecurity, and a professor of epidemiology in the St. Louis University College for Public Health and Social Justice. She is a PhD nurse researcher with an emphasis in infectious disease emergency preparedness. In addition, she is board certified in infection prevention and epidemiology and a fellow of the Association for Professionals in Infection Control and Epidemiology. And so we please welcome Dr. Terri Rebmann.
Thanks for having me here today. I'm going to share my screen. I brought a slide set to talk through. So the title of my presentation today is the COVID-19 pandemic. Where have we been and where are we going? So the objectives, I'm going to describe what's happening in terms of the current epidemiology of the pandemic, talk about what we've done in the past in terms of how we approached pandemic mitigation and where we're moving as a society in terms of this particular pandemic. And then I'm going to try to predict what's going to happen for the remainder of the pandemic, which no one knows for sure exactly what's going to happen, but I'll talk about maybe what's likely to happen with the pandemic moving forward. So just a quick look at the, this is the Epicurve for the United States with this pandemic, starting way back in January of 20 when it was first identified here in the US. So as you can see, there have been a number of pandemic waves that have occurred. The waves, if I've actually removed Omicron wave, which is the wave on the far right of the screen, the other waves would look a lot bigger and more dramatic. But because Omicron has basically just dwarfed everything else that we've seen so far, it makes everything else look a little bit flatter. But as you can see, in 2020, late 2020, we started to see our first huge wave of COVID-19. And it was also around that same time that vaccine first became available. And soon after the vaccine became available, then we started to see a very sharp decrease in cases. And then things kind of leveled off for a little bit. And it looked like maybe the pandemic was starting to go away, or things were definitely improving. And so the CDC went ahead and lifted their mask mandate at the federal level. Again, the belief was with vaccine being available, and it was widely available by that time because it was May of 2021. And because rates were so low at that point, that we believed that the pandemic was going to end, or at least not be a major issue for a number of months. Then, of course, it was not that much later when we saw a rapid increase in cases due to the Delta variant that popped up. And Delta was a more severe variant, which I'll talk about in just a minute, and caused that next big wave, not quite as bad as the wave in 2020, 2021, but a very substantial wave. And just as Delta started to sort of go away, then we had the massive wave due to Omicron, with the worst peak that we've seen in cases so far. Now, of course, we are at the very bottom of the Omicron wave, and hopefully things will continue to go down, although even at this point, rates are extremely low in terms of the United States. So when I take out the Omicron wave, then you can see a little bit better, as I said before, those previous waves prior to Omicron, because it looked more dramatic when you didn't have that massive Omicron wave on the screen. So again, you can kind of see here where we had that big wave in the winter of 2020, 2021, vaccine became available, big drop, mask mandate went away, Delta started to hit us, and then the mask mandates, of course, came back and have been in place until very recently. So clinical features of COVID-19, there's a range of illness, and it really depends on which variant we're talking about. The incubation period is pretty short, 2 to 14 days. It's even shorter for Delta and Omicron. So generally speaking, you can even have like a 24-hour incubation period with both Delta and Omicron variants. In general, this is a respiratory disease. So we tend to see, if individuals have symptoms, it tends to be fever and respiratory symptoms like a cough, runny nose, shortness of breath. But we know that there's quite a bit of asymptomatic and mild disease that's also possible, more so with Omicron than with Delta. We also now have a lot of data looking at the impact of getting COVID-19 while you're pregnant. And so what we have found is that, so for a long time, we believed that the major high-risk groups for COVID-19 were individuals who were over the age of 65 and those that had comorbidities. And that continues. That is still the #1 risk factor, is age and comorbidities, and especially the combination of the two. But we also have found that pregnant women are at very high risk for severe COVID-19. They have an increased risk of hospitalization, needing to be in the ICU, and needing to be on a ventilator. Now, the good news is that we don't have any evidence of vertical transmission, meaning that a pregnant woman who gets infected with COVID-19 does not pass it on to her unborn child. Instead, after that baby is born, then that neonate can develop COVID-19 if the mother is still infected, because the mother then spreads it through respiratory droplets. But in general, for babies, COVID-19 tends to be an asymptomatic or mild disease. So it's actually worse for pregnant women than it is for young babies. We also know vaccination during pregnancy is absolutely critical. We now have data on hundreds of thousands of pregnant women that have found that COVID-19 vaccine is very safe and effective for pregnant women, and highly recommended in order to prevent severe disease among those pregnant women. So now let's talk about the Delta variant. So the Delta variant was first identified in spring of 2021, and it really changed the landscape of the pandemic. It was more transmissible. It transmitted much faster and easier than the ancestral strain of COVID-19. And it was also associated with an increased severity. So there was a higher risk if you got infected with Delta, that you're more likely to be admitted to the hospital, need oxygen if you were hospitalized, to be in an ICU, and to die from COVID-19 compared to previous strains of COVID-19. Vaccine in general was pretty protective against the Delta variant. We did see small amounts of vaccine breakthrough, but in general, those that were vaccinated were significantly less likely to need to be hospitalized or to have severe illness compared to those who are unvaccinated. The Omicron variant looks in a lot of ways very different from the Delta variant. So it was identified that week of Thanksgiving of 2021. It feels like it's been around forever because it had such a huge impact locally and nationally. But the first case wasn't identified in St. Louis until December the 3rd. So the Omicron variant was first, so it made the news because it was first identified in South Africa, but it was actually believed to start in Norway. But our data, our good early data on Omicron came from South Africa. And what they saw in South Africa is that there was this very, very sharp trajectory of the Epicurve, so really high infection rates that increased very, very quickly, but then there was also a very sharp decline. So the entire pandemic wave with Omicron only lasted about 4 weeks, which a month in some ways feels like a very long time, but in terms of a pandemic wave with COVID-19, it's actually a very brief amount of time because the waves have been much more prolonged throughout this pandemic. But the good news with Omicron, even though we found out it was even more transmissible than Delta, so it just spread very, very easily from person to person, but it was associated with lower hospitalization rates than during previous pandemic waves. So it is significantly less severe in general than the Delta variant or even the ancestral strain. So that's the good news. It's more transmissible, has huge infection peaks, but in general, it causes less severe disease. Now, that being said, when we see massive jumps in cases, as we did with Omicron, statistically speaking, you're still going to get a number of people that end up with severe disease because it's not mild in 100% of the individuals. So we did still see very high hospitalization rates. Our ICUs were full, our hospitals were full with COVID. We were almost out of ventilators. So I would not characterize Omicron as being a strictly mild variant because it did still cause severe disease for individuals, and it definitely had a very negative impact on our healthcare surge capacity. So in terms of how COVID-19 is transmitted, it's transmitted by infectious respiratory particles. The definition of exposure means that you've been closer than 6 feet with somebody who's infected for 15 minutes or more when you're not wearing masks. Individuals who have what we call a continuous exposure has increased risk. So in other words, the more time you spend with somebody who's infected, the higher your risk of getting the disease. So household members are going to be the highest risk individuals because they have that continuous exposure. They're spending hours a day with those infected individuals. And so even if you try to isolate from each other in the same household, there's still a really high risk of becoming infected when you live with somebody who has COVID-19. You don't even need the 15 minutes of exposure if you have direct contact with somebody's respiratory secretions. So for instance, if someone that's infected coughs or sneezes on you, then you have a high likelihood of getting infected as well. But the infection risk, it's more complicated than that. You have to look at a number of different factors. The risk is on this continuum of, there are a number of factors that come together to increase your risk of getting infected. So for instance, if an individual is projecting their voice or if they're singing, they're going to be putting a lot more infectious particles out into the air. So that increases the risk of spreading disease. If there's a lot of turbulence in the air, if the air is moving very quickly, like if you're in a windy area or in a space where there's a lot of air movement, that's actually going to decrease your risk of getting infected. If you're in a larger space with an infected individual, that's going to lower your risk of getting infected because there's just more air to dilute out those infected particles. So you're inhaling fewer of them. If you're outside, you're safer because in general, there's more airspace around you and it's very difficult to transmit the disease in outside settings in general, especially when you're far apart from others. The amount of time you spend with somebody, of course, plays a role. So the shorter amount of time you have exposure to somebody who's infected, the lower your risk, versus if you spend large amounts of time with them, that's going to increase your risk. And then the crowdedness of a space also plays a role. So if you're in a more crowded environment, then you're at bigger risk of becoming infected. And then lastly, masks. So masks and respirators provide protection. I'm going to talk about that in more detail, but whether you're wearing a mask or the other individual is wearing a mask also plays a role in the risk of becoming infected. So when you look at that as a whole, you kind of come up with this sort of joint probability of becoming infected. So it's not as easy as just, did you spend 15 minutes with somebody who is infected? It's all of these factors together kind of increase or decrease your risk of becoming infected. So now let's talk about masks. And let's start in masks for the general public. So masks for healthcare, that's a whole other issue, and we know that they're necessary, so we're not going to talk about that. But for the general public, so at the beginning of the pandemic, as all of you will probably remember, the CDC and other public health officials had said that they didn't recommend that people in the general public wear a mask unless you were sick. So if you had symptoms, they recommended you wear a mask to your healthcare provider to be evaluated, but otherwise they didn't want the general public wearing masks. And there were a couple of reasons for this. One was that they were afraid that it would give people a false sense of security. Two, we were afraid that people, if they didn't know how to wear a mask correctly, that they might accidentally infect themselves from the mask because the outside of the mask becomes contaminated while you're wearing it. And so if you touch the outside of the mask and then you remove the mask and you touch your nose or your mouth, you can actually infect yourself that way by not wearing that mask or respirator correctly. And then the most important reason, which they did not do a great job of communicating this to the public, but early on in the pandemic, the primary reason why we didn't want the general public wearing masks is because we needed to conserve them for healthcare personnel. We didn't have enough masks and respirators stockpiled for our healthcare workers. They were going through them very, very quickly because they are single-use items. So they put on a mask, they go in to take care of a patient, they leave the patient's room, they throw that mask away. The next time they go in, they need to get another mask. So they were going through hundreds and thousands of masks very, very quickly, and they just didn't have enough to go around. So the concern was that if the general public had masks and were buying masks, then we wouldn't have enough for our healthcare personnel. And we knew the healthcare personnel were at highest risk of getting COVID early on in the pandemic. But we really did not do a good job of communicating that. And it led to a lot of confusion throughout the remainder of the pandemic. And I still hear people talk about that to this day. So then sort of in the middle, the early middle of the pandemic, so pre-vaccine in mid to late 2020, the CDC came out and said, yes, we do recommend universal masking for the general public. We know that it's very effective. We know it works when everybody is masked, regardless of the kind of masks they're wearing. It's better if you're wearing a more protective mask, but still, if everybody is masked, it's a safer environment than if everyone is not masked. Then after the vaccine became widely available in spring of 21, we had hoped that with the vaccine becoming available, that we would reach herd immunity, that we would have enough people with vaccine-induced immunity that the pandemic would end, and that we could move away from universal masking. We saw, as I mentioned before, with the Epicurve, rates were dropping very, very quickly. And so the recommendation was that only people who were unvaccinated needed to remain masked. The belief was if you were vaccinated, your risk of getting infected was extremely low, and your risk of spreading the disease, even if you did become infected, was very, very low. And so they said vaccinated individuals did not need to be masked, unvaccinated people did need to be masked. But unfortunately, what we saw was that those who chose not to get vaccinated were also less likely, less willing to wear masks. So basically, we went from universal masking to nobody was masked, and we really started to see issues with disease transmission in the community. So that did not transition as well as we had hoped that it would. So then later in the middle of the pandemic, so post the Delta wave that started to hit in late summer, we went back to universal masking. And that was because Delta transmitted so much easier than other strains, and because it caused more severe disease, so more virulence compared to the ancestral strain, and because we were seeing low rates of vaccine breakthrough. And so we went from only having the unvaccinated individuals masked to going back to universal masking. And what we found is that we really started to see a lot less tolerance among the general public. People were tired of the pandemic. Individuals were very tired of being masked. They were disappointed that the vaccine didn't prevent the need for masking. So I heard a lot of individuals say, you know, I got vaccinated. I thought that meant that I got to be mask free, and that's not true. And so why did I bother getting vaccinated? They missed the point that the vaccine was protecting them against severe disease, and they were sort of focusing on that masking aspect. As I mentioned before, those who oppose vaccine often also oppose masks. So we had a lot of pushback from the general public about going back to universal masking. And I really started to hear a lot more from individuals that there was either confusion about the science or disbelief in the science, and people stopped believing the CDC and stopped believing the research, and even epidemiologists such as myself, as we tried to talk through the science and why these changes were being implemented. So fast forward to now, and we are moving away, of course, from universal masking at this time. So let's talk about the latest guidance from the CDC in terms of masks and respirator selection. So we know from looking at data, and we now have more than 2 years of data, and I would actually argue more than that. We've been studying masks and respirators for 30 plus years. We have hundreds of studies now on masks and respirators. And we know that all masks and respirators are not created equal. So you can kind of lump them into essentially two categories. There are masks, and then there are respirators. And then within masks, there are two different categories. And within respirators, there's two different categories. But first, let's talk about masks. So masks can either be the cloth face masks, any kind of homemade, or it might be something that you bought at the store, but a cloth mask may or may not have a filter in it, might be a single layer, might be multiple layers, but all of those cloth masks together, they are the least protective in terms of the different types of masks. The next category of masks are surgical masks. There's actually more than one kind of surgical mask, but let's just keep this easy for the purposes of today, and we'll just lump them all together and say the surgical masks, or people might call them medical masks, that are used in healthcare settings, but you can also purchase them and wear them in the general public. Surgical masks are actually very protective against COVID-19 as long as it has a tight fit on your face. So I put two pictures of surgical masks on the slide for you. In the picture on the left, you see the female healthcare provider, and you can see there are gaps on the side of her mask. So that is a surgical mask, but that's kind of loose. So that is going to allow infectious particles to escape around outside. So if she's infected, she might be exposing other people. And it also means that she's going to be at risk of exposure because the infected particles can get around the side of her surgical mask. And then next to that, there's a picture of a mannequin wearing a tight fitting mask. This was a picture from a study that was done on masks. And as you can see, it's tightened. There's a little knot on the side. This tighter fitting mask, there's a lot of evidence that the tighter fitting mask is much more protective even than that loose fitting surgical mask. So if you're going to wear a surgical mask, I highly recommend that you wear it very tightly against your face. The next category are the respirators. So some people also call them masks. Technically, they're their own category. A respirator is a certain kind of mask device. It is regulated by NIOSH. It's an occupational health group, a federal agency, but it is essentially a mask. It's just a more protective mask. There are two categories of respirators. There are the KN95s and then N95 respirators. And technically there are others too. There's like an N100 and N99, but in general, we talk about KN95s and N95 respirators. The KN95s are essentially N95 respirators that are made in other countries. So they're not regulated by NIOSH in the United States. So in other countries, they are considered equivalent to N95s, but here in the US, when we have evaluated them and looked at the science, what we have found is that the KN95s, because they're not regulated and they're not tested the way our N95 respirators are, that they're not as protective as an N95 respirator. And the CDC has found that about 60% of the KN95 respirators that you buy online are actually fake. So they say they're KN95s, but they're actually not. They might have the correct name of the company on them, but they're really not legitimate KN95. So if you want to buy KN95s, I recommend you go to the CDC website and you can just type in KN95. They have links to where you can buy legitimate KN95 respirators to wear as your mask choice. And then the N95 respirators are the most protective. They are regulated by NIOSH. So they're going to have the tightest fit to your face. They have the highest filtration level, but they're very hot and uncomfortable. So for wearing for long periods of time, you can do it, but it's very challenging because it's so uncomfortable to wear the N95s for long periods of time. So in general, I recommend individuals not wear an N95 unless you're a healthcare worker and you're taking care of patients with COVID, in which case you need that level of protection. But otherwise, for the general public, unless you can comfortably wear that N95 for long periods of time, I think you're probably better off choosing a KN95 or just a tight-fitting surgical mask that will still provide you a great deal of protection, but will be significantly more comfortable for you, which means that you're going to be able to wear it more consistently. And consistency and tight fitting are going to be really your two biggest strengths in terms of choosing a mask or respirator. So the type of mask matters, as I just said, as I described the different categories of masks, but really universal masking is going to be the most protective space that you can be in. So if somebody who has COVID-19 is not masked, but you are masked, your mask or respirator gives you some level of protection. A great deal if you're wearing an N95, a good deal of protection if you're wearing a tight-fitting surgical mask, less so if you're wearing a cloth mask. If the person that has COVID is wearing some kind of mask, but you are unmasked, you get a large amount of protection because the mask that the infected person is wearing is blocking a lot of those infected particles from getting into the air. But really the best protection is universal masking, meaning everybody is masked. So the carrier, the infected person's wearing a mask, you as the uninfected person is wearing a mask. And regardless of what kind of masks those two individuals are wearing, that's the highest level of protection that we have against COVID-19. So now what the CDC is saying is that universal public masking decisions at the local level should be made based on what's happening in the community. So they recommend looking at the COVID-19 transmission rates in your community to decide whether or not there should be a mask mandate in place for universal masking. So they say that if there are low or medium transmission rates, then it's a personal choice as to whether or not you would be masked. And then during periods of high community transmission rates, then they recommend a mask mandate in indoor settings anytime you're in a public space. The advantages to this new approach is that it really shifts to more personal responsibility, because masks are not done, should not be just one safeguard. So you should be vaccinated. That's going to provide you a great deal of protection. And then you can personally make the decision to wear a mask that provides you an additional layer of protection. You can also avoid very crowded spaces, which provides you, again, another level of protection. This also means that it reserves masking for the worst situations. We know masks are uncomfortable, people don't like to wear them, and they do create some challenges. Hearing and being heard when people are masked. There are other issues. Some people report that they have more anxiety when they need to be masked. So if we're not masked all the time, and instead we only have universal masking during higher periods of transmission, that means that people are more likely, or hopefully people would be more likely to comply, because then the science is telling us, we know the masks work and rates are really high. Now is the time for everyone to be masked. And the hope would be that the community would get on board with that. The disadvantages to this, and I don't mean to say anything against the CDC's recommendations, but it's my personal opinion that if you wait until rates are high, then it's almost too late to do a whole lot of help. Severe infection, hospitalizations, and death rates always lag behind infection rates. So when rates start to go up, you won't see hospitalization rates go up right away. It really doesn't happen until about 2 weeks after infection rates have started to go up. And so if you wait until there's high transmission, it's already spread to a great deal of your community, and you're going to have impacts on the healthcare system. So it's my personal opinion that it'd be better to go to masking at a medium community transmission rate rather than a high community transmission rate, but I don't make those policies, at least not at the federal level. We know that universal masking is more protective, and unfortunately, when we are, especially in a space where we have medium community transmission rates, it's really not protecting the vulnerable individuals. They might personally choose to wear a mask or a respirator, but that's not as protective as universal masking. So we are putting our vulnerable people at risk by waiting until there are high transmission rates. And I'm hoping at some point that this recommendation changes. So now let's talk about the vaccine. So the primary vaccination series for COVID-19, there are two types of vaccines. There are the mRNA vaccines, and then there is the viral vector vaccine. So the mRNA vaccines are the Pfizer vaccine and the Moderna vaccine. Pfizer is now FDA approved for individuals who are over the age of 16, and it is authorized for those who are 5 to 15. And it is a 2-dose series for those who are over the age of 5, except for those who are immunocompromised. So if you fall under the category of being immunocompromised, then it is a 3-dose series to complete your primary vaccination. Moderna is FDA approved for those over the age of 18, so it's not available to children who are between the ages of 5 and 17 years old. It is a 2-dose series, just like Pfizer. And it's, again, a 3-dose series if you are immunocompromised. The viral vector vaccine is Janssen, or the J&J vaccine. It is currently still under the EUA, so it's not yet fully FDA approved. But it is a single dose for those who are over the age of 18, so it's not available for children of any age at this point. The CDC, based on current data, the mRNA vaccines are highly preferred over the J&J vaccine. And that's because there is a higher risk of serious adverse events with J&J. It's not a high risk, it's a higher risk compared to the mRNA vaccines. And I'll talk about that in just a second. But first, let's talk about vaccine breakthrough. So vaccine breakthrough is when an individual has completed their vaccine series and or received their booster dose, and they still become infected with COVID-19. That's what we call vaccine breakthrough. Vaccine breakthrough is fully expected. There is no vaccine that is 100% effective. The COVID-19 vaccines are actually highly effective. They're one of our best vaccines. The early vaccines against earlier strains were about 90% effective, a little less effective against Delta and Omicron, but still 90% effective is a very high effectiveness rate for a vaccine. The flu vaccines that we get every year range from year to year, depending on how which strains we selected to go into that vaccine. But in general, the vaccine effectiveness for flu is only between 40 and 60% effective. So really, COVID-19 vaccines are highly more effective, much better vaccines than flu vaccines in general. Now, we are seeing increases in breakthrough cases. A lot of that is because more people are vaccinated. So it's not that we're seeing a loss of vaccine effectiveness, it's that more people are vaccinated. So we're just going to see more cases of breakthrough. In addition, we are seeing more cases of breakthrough due to the Delta and Omicron variants. When we look at the breakthrough case rates, what we see is that it's more likely if you're over the age of 65 or immunocompromised to be a breakthrough case. This is similar to what we see with influenza vaccine protection rates. So individuals who are over the age of 65 or those that are immunocompromised are less likely to have full immunity from an influenza vaccine. They're more likely to be a breakthrough case. And we also see there's more breakthrough cases in areas that have low vaccine uptake. So like if you look at the greater St. Louis region, the area with the lowest vaccination uptake rates is in North St. Louis compared to, let's say, West County or South County. So because there's less vaccine uptake in North St. Louis, then you're more likely to see breakthrough cases in those individuals who are vaccinated. And that's because there are just more infected people in those spaces, more vulnerable people, because they have so many unvaccinated people. And your vaccination is just less protective for you when you're around a lot of other people that might be infected. We also did see more breakthrough cases with Omicron variant. So the vaccine was proved to be less effective with Omicron. Still very effective and highly protective against severe illness and death, but there were a lot of breakthrough cases with Omicron. So in terms of how much protection you get from vaccination, it's not that the vaccine prevents illness 100% of the times. Again, we are seeing breakthrough cases, but it does protect you against, in general, it's highly protective against severe illness, hospitalization, and death. So it reduces your risk of becoming infected by threefold, but more importantly, it reduces your risk of severe illness by tenfold. So that's the main purpose to get vaccinated. Is it's not that it's going to necessarily protect you from disease, but hopefully it will protect you against severe illness. So here's some data that shows the protectiveness with vaccination against hospitalization. So as you can see, when we look at the age-adjusted rates of hospitalization by vaccine status, unvaccinated individuals have a much higher rate of hospitalization compared to those who are, at this point, they were still talking about being fully vaccinated, but I'll talk about that in just a minute. But as you can see, the green line is significantly lower. The risk of hospitalization, if you've been vaccinated, is very, very low compared to those who are unvaccinated, where the rate is very, very high or can be very, very high. So do the vaccines have side effects? So let's talk about the mRNA vaccines first. So yes, they do have side effects. Usually they're minor, usually last 1 to 2 days. That's just your body's immune system telling you the vaccine is working, it's your immune system kicking in. We have seen some cases of severe allergic reactions. So if you have a history of severe allergies, you should talk to your primary care provider before getting vaccinated. Then rarely we've seen, and very, very rarely, there have been cases of myocarditis or pericarditis, which are both cardiac issues. And primarily these have occurred in adolescents and young adults. and more often in males. And it's significantly more likely to happen after their second dose of mRNA vaccine than after their first dose. But relatively speaking, this is still very, very rare, and so rare, in fact, that it's recommended that you still get vaccinated, even if we're talking about an adolescent or young adult who is a male, because the risk from COVID-19 is significantly higher than the risk from the vaccine. So in terms of the J&J vaccine, does it have side effects? Yes, very similarly to the mRNA vaccines, tends to be very minor, usually lasts 1 to 2 days. Again, that's your body's immune system. There have been some cases of severe allergic reactions to J&J, but the real issue with the J&J vaccine has been TTS, thrombosis with thrombocytopenia syndrome. So it's this blood clotting disorder. It's very rare. The rate is only 7 out of every 1,000,000 individuals. In general, it has occurred more likely in women who are under the age of 50. But because it was first identified as this possible association, they paused use of J&J vaccine in 2021 for a couple of months to do some more evaluation on it. And then they did go ahead and resume the use of the J&J vaccine. But now what they're seeing is that the rate of TTS is about 57 out of every 18 million people who have been vaccinated with J&J. So again, very, very low, very rare, but still, because of the risk of TTS, that's the reason why the CDC is saying the mRNA vaccines are highly preferred over J&J. So when we look at the data on children under the ages of 5 in the COVID-19 vaccines, many of you may have heard on the news, the FDA just evaluated some of this data. The manufacturers were considering applying for authorization to use this vaccine in children who are under the age of 5. But what they have found in the clinical trial data is that the mRNA vaccines are not as effective in children who are under the age of 5. And so instead, they are now considering maybe trying to get FDA authorization for a 3-dose series for children under the age of 5. But even with that, the 2 to 3-year-olds, the data appears as though it's still not effective. Even this 3-dose series, it's still not as effective in that age group compared to older children and compared to adults. So the worry is that if we go ahead and get the vaccine authorized for these very young children, that parents aren't going to support it because there's a risk from the vaccine and that the vaccine is just not that effective at this point. So instead, they've decided to collect more data and see if there really is, if this appearance of being less effective in this age group is true in a bigger population, or if this is like truly that the vaccine is just less effective in children for some reason. So again, they're going to continue to study it before they try to get authorization. So now let's talk about the 3-dose series versus the booster doses, because I know that this causes a lot of confusion for individuals. So as I mentioned before, those who are falling in one of the categories of being immunocompromised, it is recommended for the primary vaccination series that you get 3 doses of an mRNA vaccine. And the reason for that is because even though for most adults, you build full immunity after the first 2 doses, for those who are immunocompromised, their immune system just isn't working as effectively. And so it takes them more doses in order to get to that level of immunity that others get at 2 doses. So for instance, in the clinical trial data, they found that for those who are immunocompromised, it was only the 2-dose series was only 71% effective at preventing illness versus 90% in all other adults. And in terms of protecting against hospitalization, 2 doses was only 59% effective among those who were immunocompromised versus 94% effective for everyone else. So that's why the CDC had said, okay, if you're immunocompromised, you get 3 doses for your initial vaccine, and then you would get a 4th dose for your booster dose. For everyone else, that 3rd dose of vaccine is considered a booster dose. So in terms of booster doses, if you receive the J&J vaccine, then you're eligible to receive a booster dose 2 months after you receive that J&J vaccine. And if you choose to get J&J, which is not recommended for your booster, but if you chose to do that, it would be a second full dose of that J&J vaccine. If you received either Moderna or Pfizer vaccine, that either 2-dose series or 3 doses if you were immunocompromised, you're eligible for your booster 5 months after you received that 2 or 3 dose series. For Moderna, your booster dose is only a half dose of Moderna versus Pfizer, where the booster dose is a full dose of Pfizer. So again, if you're immunocompromised, you have to do the 3-dose series first and then get your booster 5 months later. So the CDC says, or they don't necessarily recommend, but they say that you can mix and match your booster doses. So you can receive any COVID-19 vaccine as a booster dose, and it's your choice as to which to get. But again, because of this risk from serious adverse events with J&J, they highly recommend that you get an mRNA vaccine over J&J. But you could get Moderna vaccine and then get a Pfizer booster, or the Pfizer vaccine and then a Moderna booster. You can mix and match any of those vaccines in your series. So what does it mean to be, so early on in the pandemic, after the vaccine was available, we started using the term being fully vaccinated. And now we're kind of moving away from that, because now that we have booster doses, are you considered fully vaccinated if you are eligible for a booster, but you haven't received it? Like, what? There's a lot of confusion about that. So we moved away from that term, and instead the terminology that we use is up to date on vaccination. So what that means is that if you completed your primary series, that single dose of J&J or 2 doses of mRNA vaccine, 3 if you're immunocompromised, and if you're not yet eligible for a booster dose, so you're less than 5 months after you completed that vaccine series, then you are considered up to date on vaccination. If you completed your primary series and you also received your booster dose, then you are considered to be up to date on vaccination. So now let's talk about immunity from vaccine versus from infection. So let's start with vaccine-induced immunity. We don't know exactly how long immunity after vaccination lasts. It's estimated to be about 5 months at a minimum. That's how we came up with the recommendation of when to get your booster dose, is you have some vaccine-induced immunity for a relatively short period of time. But immunity starts to wane over time. So, and this is true with most vaccines, not all of them, but with most. Over time, your immunity against that disease will start to wane. And what we saw, especially with the Omicron variant, is that reinfection became more likely. So we saw more breakthrough cases, and we saw you could be infected with Delta, and then very quickly after, you could also get infected with Omicron. So vaccine-induced immunity was not lasting as long with Omicron compared to some of the other variants that we have seen. So in terms of natural, what we call natural immunity, so if you get infected with COVID-19, then you develop what we call natural immunity. Your body develops some defense against that disease. We don't know exactly how long natural immunity lasts. It's estimated to be a few months at a minimum, and may even be longer than immunity from vaccine. However, and I know that I've heard individuals, especially those who are opposed to vaccine, will say, well, if I get longer immunity from the disease, I should just go ahead and get infected and then I'm protected. That's a really risky approach to take, because once you get infected, you run the risk of having things like long COVID, which are the long-term negative outcomes from getting COVID-19. You have that risk of hospitalization and that risk of dying from the disease. So it's far better to have vaccine-induced immunity, even if it doesn't last as long as natural immunity. So it appears that most individuals have robust immunity after infection, at least for the short term. But what we see when we look at data, individuals' antibody levels, that tells us an estimate of maybe how much immunity they have, that the antibody responses vary after natural infection or after infection. So we don't know exactly how long it lasts, and it probably varies from person to person. So we know that vaccine-induced immunity is the better approach to take. Vaccination after infection is still very, very important because we don't know exactly how long immunity lasts after natural infection. And because reinfection is absolutely possible. We saw that a lot with Delta and also with Omicron. So I know there are many individuals who have been infected with COVID at least twice. Some have been infected 3 times with COVID now and remain susceptible to disease moving forward. We also have some data that shows that for those who were infected and then received 1 dose of mRNA vaccine after that, they actually had higher antibody levels than those who had been previously infected but did not get a dose of vaccine. So that what we call hybrid immunity, when you have natural immunity plus vaccine-induced immunity, is really the strongest level of immunity that you can develop. But if you have been infected with COVID-19 and if you received the monoclonal antibody treatment, you can't get vaccinated for 90 days. So you do have to wait a little bit if you've been treated for COVID-19. So now let's talk about what's going to happen or what might happen for the remainder of the pandemic. Well, of course, it's hard to tell exactly. No one knows for sure exactly what's going to happen. My crystal ball has been foggy for 2 years now. We can make educated guesses based on what has happened in the past and what we think might happen moving forward. It's likely that we're going to have low rates at least for the next few months, but a new variant could pop up and could change that, just like Delta did last year. We expected to have low rates for at least a few months last spring, and then Delta came around and changed the pandemic landscape. It is likely that we will see another wave in the fall or winter, even if we don't see a huge wave between now and then. And that's because it is a seasonal pathogen, it's a respiratory virus, and they tend to rise in the fall and winter and then decrease in the spring. In terms of new variants, so the virus that causes COVID-19, SARS-CoV-2, mutates. That's what viruses do. They change and mutate over time. They can evolve very, very quickly. The pictures on this slide show the percentage of variants that are occurring in the population of the samples that have been tested. So in other words, if you look at the bottom, you can see week by week. So if you look at like 5/8/21 on the far left of the slide, you see some pink, which is B152, and then a little bit of P1, and then a lot of B117. And then as you go across week by week, you can see the colors are changing. What that means is that the percentage of variants happening or occurring week by week is also changing. So on the far left-hand side, you can see that the light orange was the alpha variant. And so that was the vast majority of the variants we were seeing back in May of 2021. And then in June of 2021, you start to see the darker orange, the B16, start to increase. That's the Delta variant. And as you can see, Delta started very, very small in May of 21. It was a very tiny percentage of the variants we were seeing. But then by July, it was almost everything we were seeing was the Delta variant. So Delta really came in and took over in the population and became the predominant strain that we were seeing. And then throughout from July until October of 21, it is almost all Delta, as you can see on the right-hand side. So almost everything we saw in the United States was Delta for those couple of months. But then Omicron took over and it hit even faster than Delta. We were really surprised by how quickly Delta took over in the population, but Omicron there was just no comparison. As I mentioned before, it was first identified in the US that week of Thanksgiving, first week of December. And then by early January, in less than a month, it was more than 95% of all circulating strains. So Delta took a couple of months to take over. Omicron hit in less than a month. It was very, very fast. So as you can see, the dark orange on this slide is Delta and the purple is Omicron. So you can see Omicron showed up. It was about 10% of the samples on December the 11th. And then by January the 8th, it was 99% of all of the variants that we saw. Human coronaviruses in general, so not just COVID-19, but human coronaviruses in general usually only occur in children. The disease usually only occurs in children. It's usually a very mild disease. It's more like a cold, and it's usually a seasonal pathogen. It's a respiratory virus. We see human coronaviruses that infect children every year, and it tends to have a fall or winter pattern. This hasn't been completely accurate for what we've seen for COVID-19. So COVID-19, SARS-CoV-2 is a human coronavirus, but it looks very different in terms of how it is circulating in our population compared to the other human coronaviruses that we see among children. So it's not a good comparison to look at other human coronaviruses. So let's look at other pandemics. So the other major pandemic that we've had that was really bad was the 1918 Spanish flu pandemic. And originally we were expecting COVID-19 to look somewhat like Spanish flu in terms of the waves and how we might have a few waves and then it might go away. And what we saw with the Spanish flu pandemic was that there were three very distinct waves. There was the first wave in spring of 1918 with very mild disease, and it was a relatively small wave. And then not that it went away, but it went very, very low rates for a number of months. And then in the fall of 1918 and the winter of 1918, 1919, we had very, very high rates of infection, and the virus had mutated and it became much more deadly. So it became more virulent disease because the virus had mutated. And then the third wave that we saw in winter of 1919 and winter of 1920 is that we had a last final wave of Spanish flu, and it kept that high mortality. So it was a more deadly disease, but it wasn't as high. It didn't infect as many people. And it turns out that the way that the Spanish flu pandemic played out was not a good predictor of the COVID-19 pandemic. Of course, we've had many more than 3 waves, and we haven't seen the very high mortality that we saw with Spanish flu. Spanish flu mortality reached a very high rate, almost 10%, and we just have not seen that with COVID-19. Delta was more severe, but it did not reach a 10% mortality rate. So is there going to be a fourth booster dose that's going to be recommended? Well, at this point, it's really too soon to say. During Omicron, when it hit, Israel they mandated boosters of everybody, and they showed that fourth dose was really not helpful. What we don't know was it too close to the first booster that they received? So maybe there just wasn't much additive benefit. Or was that specific to Omicron because Omicron looked so different than the other variants that we've seen? So maybe it just was better at evading the vaccine-induced immunity. We really don't know for sure. The vaccine manufacturers right now have been working on an Omicron-specific vaccine. They're hoping that's going to be available very soon. If that does become released, it's possible that the CDC will say that they will recommend a fourth dose for individuals, or they might not. They might say that it's optional. We really don't know yet because we're still collecting data. In terms of other COVID-19 safeguards, the CDC says that you should base other decisions on what's happening in the community. So kind of like with with masking, they say you look at what's happening in your community and you look at what's happening in your healthcare system and you make your decisions based on that. So when you have low transmission rates, then they just recommend individuals be vaccinated, get tested if you have symptoms, but very few other safeguards are needed. Versus during high transmission periods when they say universal masking should be in place, everyone should still be vaccinated, get tested if you have symptoms, and then maybe even additional precautions, limiting capacities, social distancing, all those safeguards that we've seen before. So the purpose of that combination of safeguards is really to try to flatten the curve. So, and by flatten the curve, I mean, so when we have those waves of the pandemic and waves of cases, if you have those safeguards in place, you might be able to level that off. So you have either fewer cases of illness or spread out over a longer period of time so that the healthcare system has time to be able to take care of everybody. what we saw with Omicron was there were so many cases so fast, the healthcare system could not keep up. There wasn't enough testing capacity. There weren't enough physician office visits, and you just weren't able to get in and see a provider if you had symptoms, and you could hardly get a test. So what we're trying to do is kind of make it a little bit easier for the healthcare system to respond. So we use those safeguards to flatten that curve. And so the final question is, will COVID-19 always be around? We're really not sure at this time. It's possible that it will continue to mutate. It might become even milder than it is with Omicron. It could become endemic. We might just need to learn to live with it. It might just pop up every fall and winter, kind of like the flu. Might be something that we maybe just get an annual COVID-19 vaccine like we do for the flu, but we're able to manage the outbreaks a little bit better. Or it could go the opposite direction. It could mutate again, but in a negative way, and we could have additional waves. It could cause more severe disease. So we really don't know exactly what's going to happen next. We do know that global vaccination is going to play a key role. We're still at a point where globally, only about 3% of individuals in low-income countries have received any vaccine at all. And that's really where the mutations are taking place. That's where the new variants are forming. Because when you have a population with a lot of disease transmission and there's not much access to vaccine, that disease transmits very easily. You get a lot of infections, it mutates easier. And then once you have that new mutation, it's easy to spread from person to person, and it can be imported into countries that have higher vaccine. So that's what we saw with the United States. The vaccine, our Omicron and Delta, both started in other countries and then got imported here, and of course had major impacts on our community. So the key is really to get global vaccination in place so that we can try to stop this pandemic, or at least turn this into something that's more endemic and easier to live with. So with that, I'm going to stop sharing my screen because oh my gosh, we only have 2 minutes left. I apologize. Not much time for questions.
Well, we have a couple in the chat box from while you were talking. Okay. So we have, at the very beginning, there was a question from Julia. Does mild just mean not put on a ventilator when you're talking?
Yeah, so technically the definition of mild just means not hospitalized.
Okay. And then Ellen says, the New York Times recommends KN95s that are not on the CDC list. What to do?
I personally like the CDC list just because it's been vetted and we know that they are legitimate KN95s.
Leslie says, I'm not sure, it might have had something to do with what you were saying at the time, but where is the St. Louis area? Leslie, did you want to?
In terms of our current rates?
Right, yes, in terms of our current rate. Because I don't know if we're low or middle, and I don't know if I should be wearing a mask or not.
We're very low right now. So right now the positivity rate is less than 5%, which is the cutoff for low transmission rates. I can tell you, I'm still wearing a mask in especially crowded public spaces or in spaces where I don't know individuals' vaccination status. So when I go to the grocery store, I still wear my mask.
Okay, thank you.
Ellen has just a second, a couple more questions in the chat that came up earlier. Ellen asks, if people over 65 are more vulnerable, should they get another booster?
So a fourth booster you're not eligible for that yet. We don't have enough data for that. So you would not be able to get a fourth booster at this time.
Okay. Myron has two questions. When or should we get a second booster? And do you think, I guess that would cover the question. And do you think we will need a yearly booster from COVID-19?
I do think there's going to be an annual booster. I apologize, it's 11 o'clock. I have to run for a leadership meeting at 11. If you want to email me questions though, I'm happy to answer those.
Okay. So I'm
Thanks
sorry.
so much. I'm sorry to run.
Yes. we understand it's, you've got a really busy schedule. So anyone that, this is recording, and anyone that has a question right now, if you want to email to me, I can forward to Terri and Terri can respond. Would that be okay, Terri?
Yes, and I just put my email in the chat box.
Okay, all right. Well, and, or you can, I will send you that in an email as well, in case you want to communicate with Terri yourself. So thank you so much, Terri. We really appreciate you. I think she's gone. Thank you everyone for being here today. And we really appreciate you participating today. And sorry, we didn't get to the questions on the program. So, but you can email to me or Terri. All right. Thank you everyone. And we'll see you later. Bye-bye.